This module explores vocal pathology, the spectrum of disorders that affect the vocal folds and the broader vocal mechanism. Whether functional, structural, neurological, or systemic, these disorders can significantly impair communication, performance, identity, and quality of life. For professional voice users, even minor abnormalities can result in catastrophic career consequences if not identified and managed promptly. The module combines knowledge from otolaryngology, ENT, speech-language pathology, voice therapy, laryngology, neurology, and psychosomatic medicine, offering you an advanced understanding of the anatomical, physiological, psychological, and environmental origins of vocal dysfunction. We delve into diagnostic approaches, including laryngoscopy, stroboscopy, acoustic analysis, and the subjective assessment of voice quality, as well as non-invasive and surgical interventions. Most importantly, this module emphasizes prevention and early detection, and teaches how to create therapeutic environments that encourage vocal healing and sustainable recovery. Key learning objectives. By the end of this module, you will be able to identify and differentiate between functional, organic, and neurological voice disorders. Understand the etiology and symptoms of common voice pathologies. Recognize the diagnostic tools used in vocal assessment. Describe evidence-based treatment options, both surgical and therapeutic. Develop personalized vocal rehabilitation plans in collaboration with specialists. Promote awareness and early intervention within professional communities. Section 1. Classification of vocal disorders. Vocal disorders fall into three main categories. 1.1. Functional disorders. These occur without structural damage to the vocal folds and are often due to misuse, abuse, or psychogenic factors. Examples: muscle tension dysphonia, MTD, functional aphonia and dysphonia, puberphonia, mutational falsetto. Causes: excessive talking and singing, poor vocal technique, emotional or psychological stress. 1.2 Organic disorders. These involve physical changes to the vocal fold structure or surrounding anatomy. Examples: vocal nodules, bilateral, callus-like growths from repeated trauma. Polyps, fluid-filled, often unilateral, linked to acute injury. Cysts, submucosal fluid retention, may require surgical removal. Rhynchoedema, swelling from chronic irritation, e.g., smoking. Contact ulcers and granulomas, from reflux, intubation, or aggressive voice use. 1.3 Neurological disorders. These result from nerve dysfunction either centrally or peripherally. Examples: vocal fold paralysis or paresis, damage to the recurrent laryngeal nerve. Spasmodic dysphonia, focal dystonia causing involuntary vocal fold spasms. Parkinson's disease or ALS-related dysphonia, related to systemic neurological degeneration. Section 2. Symptomatology and early warning signs. Common symptoms of vocal disorders include hoarseness or breathy voice, pitch breaks or reduced range, vocal fatigue and strain, throat pain or discomfort, sensation of a lump, globus, difficulty projecting the voice, voice loss or aphonia. Warning, sign: any hoarseness persisting more than 2 weeks requires referral to an ENT. Section 3. Diagnostic tools and assessment techniques. 3.1 Instrumental assessment: rigid or flexible laryngoscopy. Visual inspection of the larynx and vocal folds. Stroboscopy. Slow motion-like analysis of vocal fold vibration. Acoustic analysis. Measures pitch, loudness, jitter, shimmer, and other parameters. Electroglottography, EGG. Measures vocal fold contact during phonation. 3.2 Subjective Tool Voice Handicap Index, VHI. Patient-reported voice impact. GRBAS scale. Clinical perceptual rating. Grade, roughness, breathiness, asthenia, strain. CAPEV. Consensus Auditory Perceptual Evaluation of Voice. Section 4. Common voice pathologies in depth. 4.1 Vocal nodules, usually bilateral. Affect high voice users, singers, teachers. Treated with voice therapy, rarely surgery. 4.2 Polyps, often unilateral and vascular. Sudden onset after vocal trauma. May require surgical excision. 4.3 Reinke's edema smoker's voice, low-pitched, gravelly, caused by fluid retention in superficial lamina propria, managed by smoking cessation, surgery, and therapy. 4.4 Spasmodic dysphony strained or breathy breaks in speech, treated with Botox injections into the vocal folds, requires diagnosis by a neurologist and voice team. Section 5. Therapeutic interventions and rehabilitation. 5.1 Voice therapy, conducted by speech-language pathologists, focusing on vocal hygiene education, breath support and coordination, resonant voice therapy, semi-occluded vocal tract exercises, e.g. strophonation, manual therapy for tension reduction. 5.2 Pharmacological treatment proton pump inhibitors, PPIs, for reflux-related conditions, anti-inflammatories or corticosteroids, for swelling, botulinum toxin, for spasmodic dysphonia. 5.3 Surgical interventions, microsurgery, for nodules, polyps, cysts, injection laryngoplasty, for vocal fold paralysis, phonomicrosurgery, preserving vocal fold vibration post-surgery. Section 6. Psychological and behavioral considerations. Voice disorders often carry a psychological burden. Loss of identity, especially in singers or teachers. Anxiety, depression, or performance fear. Vicious cycle. Stress exacerbates tension, worsening the voice. Multidisciplinary support may include psychologists, vocal coaches, bodywork therapists, e.g. Feldenkrais, Alexander technique. Section 7. Prevention, maintenance, and follow-up. Regular check-ins with ENT or SLP. Maintenance therapy for chronic conditions. Vocal warm-ups and cool-downs. Hydration and sleep. Limiting vocal load and using amplification. Stress management.